ringing, but it'll go away soon.
We will get this started in terms of recording. And welcome again, everybody, and turn this over to Dr. Mills. Thank you very much.
Thanks so much, and I am really excited to be with you all again for this month. I think we have a great topic that has a tremendous amount of potential and benefits to our practices and our patients. We'll go ahead and get started. Again, this is better if it's conversational and less of a didactic lecture, so I certainly welcome questions either in the chat box or ask live. Try to keep your phones muted as we can. I understand we're not having the feedback this month, which is great. I apologize for that last month. My goal is to get through this in about 50 minutes and allow 10 minutes for questions. I'll do my best to match that pace. So let's just dive in. So this is about Medicare annual wellness visits. Again, a brief reminder of who I am, where I'm coming from, and that's okay. Our agenda is to really kind of appreciate and understand the origin and importance of Medicare wellness visits, understand the requirements, which are very specific, and it's valued and paid for those specific requirements. We want to describe the benefits of systematically performing annual wellness visits, and what do I mean systematically? And we want to explore ways to incorporate those into usual workflow. And there's a couple of options, all of which work, and for most practices the answer is not any one of them, but really all of the above. So like many things, we just have to dig in. There are no miracles. There's just the roll up the sleeves and today solve this problem and tomorrow solve that problem and move forward systematically. So that's what let's do. So as is my wont, I do like to know what the brief history of a topic is, and I don't want to belabor this, but it's important to understand where we are through the lens of where we came. And I found that as I interact with my docs, engage with them, knowing how this service was built and why it was created to meet a need specifically that the House of Primary Care, and especially American Academy of Family Physicians and AOA, had been complaining about and talking about for more than a decade, does often get us over the hump of acceptance into action in our practices. So it's important to go back and remember, in 1990s leading up to 2001, healthcare had and continues to have to a lesser degree, a hugely systematic quality issue. Most providers paid attention and looked at the patient schedule for this morning in the exam room ahead of them. No one was systematically looking at data or quality. Then came 2001, the seminal crossing the quality chasm that laid this out in stark details, the summation of which was errors in healthcare and failure to address quality systematically was the effect of crashing a 747 every day in America. And I think that mental image and that concept and the evidence of systematic safety that you could generate in the aircraft industry and the nuclear power industry kind of galvanized things to where we are. So the failure at the time that was enumerated was about the failure of a disease-focused healthcare system, which was the majority of 40% of men in Medicare, 33% of women only were up to date. So the majority, or more than 50%, did not have all recommended services. It got worse in the 50 to 64 age. 75% don't have most recommended services. We knew for a given problem like hypertension, only a third of the population has hypertension. Only 2/3 of them were diagnosed. Was diagnosed. Only 2/3 were seen in the practice. Of those seen in the practice, only 2/3 were on medication, and of those on medication, less than half were controlled. And we knew that the top 3 causes of death, which have been stable for decades, heart disease, cancer, and stroke, all of them were and remain amenable to prevention efforts to improve quality, do early screening, and improve outcomes with early treatment. So we had in our power the ability to do better. As in many things, Medicare really drives the bus. Medicare is the largest single healthcare provider in the country, and so flows Medicare often flows to Medicaid and then to TRICARE. and those things together, when you add in state governments, is more than 50% of all the health care in the country. So first came the Balanced Budget Act. Remember that Medicare was invented to be a care system, a problem-focused healthcare system. 1997 Balanced Budget Act was the first time we enumerated legislated screening services to be paid by Medicare. And that's where you got certain cancer screenings, bone mass measurement, diabetes self-training, and the first idea about telehealth. Medicare Modernization Act in 2003 added the Welcome to Medicare visit, which I will touch on only very, very briefly. And then in 2008, we got the Medicare Improvement to Patient and Providers Act, MIPA, that refined the Welcome to Medicare visit, and then added some more screening services, cholesterol screening for heart disease, diabetes screening, AAA screening, and depression. Then in 2011, the Affordable Care Act of 2010 took place. Section 4103 institutes overt payment for Medicare coverage of annual wellness visit providing personalized preventative plan. That is the official title of that section. Lets you know that the personalized preventative plan and health risk assessment are core features that must be met. Then Section 4104 authorized no cost sharing. So before, all of these other separate, they were very scattered. Some would have copay but no deductible. Some would have no deductible but it would have a copay. It was a little bit scattered as each legislative act was enacted. The ACA, basically Section 4104, authorized blanket policy. Congress wisely decided to get out of the business of legislating specific benefits. They said that CMS may authorize no cost sharing, which means no deductible, no copay, for any adult preventative service graded A or B for USPSTF. And that was a seminal event in healthcare. That does require that an HRA be completed prior to or concurrent with the wellness visit. So you can't forget to do it and then call the patient after the fact. And it does require that Medicare make an HRA model available to the public, which we'll touch on briefly. And then this conversation furthers. In 2013, Transition Care Management was enacted, and January 1 of 2015, the Chronic Care Management Codes took effect. So in general, this is Medicare's decade-long response to an acknowledged problem and, request and lobbying by the House of Primary Care to say our value to our population and to our communities is not on a transactional payment basis. It's longitudinal, comprehensive care based on a primary care physician relationship, and we need time not dealing with specific problems to engage in wellness and prevention and screening with the patients. And Medicare said, okay, here you go. Now, of course, there are some details we'll touch on. First of all, so this is Medicare's service approach document where they laid out the health risk assessment details. It was actually written by the CDC, lots of input from family medicine. And on page 14, it talks about a framework. So this, I think, is useful just to lay out the philosophy. And sometimes this helps get docs over some of the frequent objections to the Medicare wellness visit. It is intended to keep Medicare beneficiaries healthy, become healthier, promote positive health habits and lifestyle. It highlights behaviors and choices that beneficiaries can adopt to improve their day-to-day functioning and quality of life. So it's all about preventative and proactive counseling and functioning. Encourage individuals to take an active role in managing their health and improve quality. Refocus on the active role in healthcare. Again, focusing on healthy behaviors. So I think that lays out very nicely their philosophical framework for the service, and that does follow into how it is built and how it's paid. Now, the annual wellness or preventative visit is interesting. Physician attitudes vary, and the AMA has done some interesting work and published in the Archives of Internal Medicine. So despite data questioning some of the validity of an annual physical exam, or it looks like about a third of doctors disagree that an annual exam is necessary, and 2/3 either agree or strongly agree. And that's interesting because that flies in the face of most evidence-based data. Physicians are sometimes slow to adopt best evidence. And for any individual service, we're all fairly comfortable that it does improve the relationship and it does provide time for counseling. We're clear, and I think it's fair to say that patients often have been trained to expect an annual visit or annual exam. And then we're more mixed whether it's of value, and a bit less than 60% say it's recommended. And we'll touch on that a bit more. So in fact, the annual physical exam has not proven to have benefit in terms of statistically improving health or reducing sickness. And in fact, the whole concept of a general health check is one of the choosing wisely, the 5 choosing wisely rules that the Society of Internal Medicine has put forward. And the best evidence truly is a routine health check exclusively for counseling and screening tests does not have great evidence. Now, there is evidence in looking at subsections of that. The only evidence for exam that it changes outcomes or has research-proven value, USPSTF A or B level, is hypertension or obesity BMI screening. The remainder of the physical exam on an asymptomatic, currently meaning today no symptoms, of a new disease or exacerbation or acute illness, it just does not have value, and we prove it in the research. Now, we all have anecdotes of that one visit with Mrs. Smith. I heard a new heart click that wasn't there, and sure enough, I found valve failure that had not manifested as heart failure yet. So we absolutely know those patients, and we all have those stories, and that routine exam remains available to you, which I'll touch on more. But at the very least, Medicare built this service to focus on the parts that had the best evidence of long-term health value, and physical exam ain't it. So there is evidence that the experience improves the delivery of preventative services, so we know that if you have time to do it, we actually do it better. No surprise there. There is evidence in the research that it does decrease patient worry, but that overall, there's not, in terms of a whole bucket of services versus any one piece, there's not tremendous evidence that it reduces morbidity or mortality specifically. Realizing all those studies had a short time horizon. Screening tests for diabetes and vaccination and cancer screening clearly has long-term health benefits and reduced costs, but the time horizon is probably, years to a decade or more. And those studies really, frankly, have not yet been done. But it is clear an annual exam, an annual visit continues to be valued by physicians. And really, when I talk to my docs, if there's pushback, I talk about, that is the standard of care for most insurance-covered patients. You tell your Blue Cross patients, we want them to be in minimum, yearly or every other year for a comprehensive visit. Now, often that comprehensive visit has a complete physical exam, which we could do less of, but at least the chance to focus on things that aren't acutely wrong is a standard. That's never been possible in Medicare until this benefit was legislated, and it makes not much sense to me why we're resisting providing the same type of preventative-focused service to Medicare patients that we expect of our insurance patients. So the annual preventative visit has tremendous benefit in terms of the things with most research evidence, which is risk assessments, screening services, including cancer screening, and actually improving the rate of delivering our preventative services. And what it allows you is freedom of distraction by all the other issues. Traditionally, we kind of tongue-in-cheek did, a quote, annual comprehensive review of medical problems, meaning we asked Medicare patients to come in for a 30-minute visit. We tried to touch on every problem, which is what we then build an E&M visit for the time to justify the time, and then we tried to cram all the preventive services on top of that. We, in general, don't do that or use that model for insurance-paying customers. So this is the opportunity to separate prevention and wellness for the Medicare patients. They may well still need an annual comprehensive review of all of their problems, but no longer do you have to work prevention in on top of that unless you just choose to do that. So let's talk about CMS requirements specifically. So there's kind of two places that are the Bible for Medicare wellness visits, and I gave you the references. This first is the MLM Matters document, And the second is the ABCs of the annual wellness visit. And again, the references at the bottom. They're easily findable and downloadable, and they're not very long. Each one of them is about, 7, 8 pages. I think one of them is 5 pages. So reading those two things, and then a selection of family practice management articles, which I include in the slide set, and I'd be happy to send full articles to Dale for dissemination. Just a little bit of reading, even a good 30 minutes, will serve to give everybody a solid understanding. But let's touch on the requirements. First of all, when can we do, in meaning for whom? So the Welcome to Medicare visit, which is a different talk and a slightly different beast, is eligible, every Medicare is eligible their first 12 months of Medicare Part B eligibility, assuming they accept Medicare Part B. So the Medicare wellness visit begins on their birth month, 12 months after they were eligible for Medicare. So the short version is the month they turn 66 and every year thereafter. Now they have to not have received one of the Medicare preventative visits over those 12 months, so it's only billable once per 12 months. A renewable resource. It's a new benefit with no deductible, no copay, so completely free to the patient every 12 months thereafter. So you do a initial wellness exam one time, no matter what age the patient is. The first one they ever have is higher valued and is an initial. Every one thereafter, no matter what frequency it is subsequent. Who can provide this? This is very clear and set out, but yet there's some interpretation which Medicare has not clarified. So the legislation says it can be a physician, it can be a non-physician provider, that's Medicare speak, specifically for physician assistant, nurse practitioner, or clinical nurse specialist. Or it can be, and the language is important, a medical professional, including or other licensed practitioner or a team of such medical professionals under the direct supervision of a physician. Direct supervision means the supervising physician is in the same office suite, under the same roof, on the same floor, and immediately available for assistance if needed. Now, that other licensed practitioner language is generally interpreted conservatively to mean an RN or LPN. Those people in most states are considered licensed nurses. A medical assistant, however, in virtually every state can be certified or non-certified, but they're not considered to have a license. So that opens up certain workflow possibilities that we'll touch on. I know there are systems that are pushing that and are having these done by certified MAs in some areas. There has not yet been a test case about whether or not that is kosher, but I think a safe, sound, and conservative interpretation is if you want staff to do these under a physician's direction, to do it with an RN or an LPN. So, annual wellness visit. Let's talk about the required elements. Now, this is very specific, so it requires a comprehensive review of past medical, surgical, social, and family history with attention to risks, meaning if there's family history of diabetes, that's an identifiable risk for the patient. You must establish, or, the first one would be establish, the subsequent would be update the list of all current providers or suppliers. At the very least, that means other consulting medical professionals or suppliers, so DME or home health. I tend to take a fairly holistic and teach a fairly holistic view of that to say anybody who interacts with you regarding your health or wellness, I want to know about. So if you see a naturopath, you see the chiropractor, you counsel with the pharmacist at Dillon's about your herbal supplements, I want to know about all of it. So you have to keep that list in a place that's visible to the team. The only exam that is required and figured into the value they're paying for this is the blood pressure screening, and height weight, specifically BMI screening. So height weight is implied, they say you have to do a BMI. Now, it's also very clear, Medicare is in no way saying you can't do any other exam. You're encouraged to do other exam as, quote, deemed appropriate, unquote, by the patient's individual risks and health status. So you can feel free to do head to foot screening physical exam if you choose. It's important to note that that time and that exam is not figured into what they're reimbursing for. There are specified screening services: cognitive impairment, depression, functional ability, home safety, and the personal health assessment, and that's the HRA, the health assessment I touched on earlier. There are basically any validated standardized assessment can be used to meet these. We've built our system to do the best, most efficient, quickest population-based screening, and then whenever you have it in positive early screening, we open it up and turn it into case finding, right? So for cognitive impairment, we do the mini-cog. If the mini-cog is positive, we push on to a full MMSE. For depression, we do PHQ-2. PHQ-2 is positive, we push full and do the full PHQ-9. Fall screen, you can simply ask, have you fallen or been afraid of falling recently? If it's positive, you do a formal fall assessment, whether you do an up and go, etc. So continuing with required elements, a health risk assessment is required. The patient has to leave with a personal preventative plan, so a written screening schedule in their possession, either physical, pushed to the patient portal, or sent to them within some reasonable time, like 24 hours. So Medicare expects the patient gets, in quick timing to when this service happens, a personalized prevention plan. And then part of that, or part of the plan of a visit note related to this, could be they need a written list of risk factors or conditions. So that's basically a plan, the assessment and plan in a traditional note, and recommended interventions that are recommended or in progress. And so this could be part of a plan of care document. It could be part of a assessment and plan going with this service. It could be part of the personalized preventative plan. You could list diagnoses and risks, and then what your current or recommended interventions are. So there are several ways to do that. And then lastly, and it's kind of redundant, there's a phrase, written personalized health advice and referral as needed. So that sentence is optional. If the patient needs other referrals or there's some advice they clearly need, then Medicare expects you would do that. And that makes perfect sense. There are 3 family practice management articles that lay out some of these details for your reference. Again, I'm happy to forward those to Dale and Jolene for dissemination. So a health risk assessment, and again, this is from that framework for person-centered risk assessments that the CDC and CMS co-authored, and it just speaks to kind of the philosophy. So in general, it includes assessment of health habits and risk factors. It includes estimation or qualitative assessment of future risk or adverse outcomes. There's a mechanism for providing feedback. At a minimum, it begins with giving an HRA and producing a feedback report that forms a foundation or part of the prevention plan. And it's an important step in raising awareness of health issues, motivating behavior change, creating teachable moments, and inspire health improvement. And so that right there is the holy grail of patient engagement. Raising awareness, creating a fair partner in their health, inspiring health improvement. And so the preventative plan and the HRA are the tools that we're supposed to use to work towards this. So Medicare does list a sample HRA that has these sections. I won't read it to you, but it's basically the sections that we just touched on. It is available in that document. It kind of has a format. It's a little bit long. It's about 4 pages. There are other slimmer versions of it, but it's important to note what Medicare's example had in it. So and then they include this interesting section, at a very minimum, an HRA includes demographic data, a patient perception and assessment of the health status. So that's one of those classic, how confident are you can manage your health? How confident are you that you can take your medication? How confident are you that you understand what your medicine is for? Those types of questions. And those then lead to SMART goals as you start moving patient behavior. So psychosocial risks, behavior risks, ADLs, and IADLs. Now there are limitations in HRAs, and again, sometimes docs have a little bit of heartburn about this, but we just need to get past any patient-supplied history or assessment, may be inaccurate due to recall bias. People may not tell us the truth about whether they have psychosocial risks, about food safety or security, about personal domestic safety, about relationships and sexual activity. Just all of that is understood. We deal with that every day in our practice life, so this is not different in that regard. HRAs often are not specifically tailored to cultural, literacy, or age groups. And you give the same HRA to the same patient year over year, you might get fairly disparate results because it's all filtered through the patient's perception, and yet at the same time, asking the patients what they think and what are their goals is critically important in changing our episodic reactive disease-focused practice culture. So here are the pieces of the Medicare Wellness Exam on the right, and I just threw it up against the Welcome to Medicare visit, again, slightly different beasts, so you can consider different. Now, it's interesting that they're not exactly the same. The bit more M includes the exam for Welcome to Medicare, whereas its formal hearing screen is required for the Welcome to Medicare, whereas the screening question is required for annual wellness. That's mainly just for your reference, but do keep straight in your head, these are two disparate, different sets of services. So we're going to touch on, and I'm going to share some of how we've built out our preventative plan tool, and that probably is something that everybody wants to work towards in one of your electronic systems or EMR. But realize that as you're adopting workflows, starting to build a new service, rapid cycle change, PDSAs at your clinic site team level, as you figure this out, don't be afraid to use paper and experiment. It's flexible, it's cheap, you can try it for the next 5 patients and then improve it. Here is a preventative plan tool from Family Practice Management. The reference is at the bottom. FPM does give blanket authorizations to copy, use, and adopt. If a person had full Adobe, they could modify this as you wanted to, put on your practice logo, etc. It is one of the potential tools to meet this, and frankly, it's what I still use in my practice. The MA keeps them in a file drawer. When a patient comes in for a Medicare wellness visit, pull it out and starts entering the data to set it up for my part of the service. So CMS lists a preventative service checklist. This is not exactly a preventative plan, but it could be the nidus of a preventative plan, right? So there's the preventative services Medicare covers. There's a place to show the date when it was last given, and there's a column where you could enter your advice for the patient in front of you regarding each of these services, whether a prostate cancer screening is not applicable to Mrs. Smith, or the pneumococcal shot is due for her in January of 2019. So this is another way to say you could build a preventative plan document fairly easily using their templates. So we're about halfway through our time. We're through 2 of 4 sections. Let's go on to the distinct benefits of the Medicare Wellness Visit. First of all, there is huge potential power to systematically adopting Medicare Wellness Visits for our Medicare age population. So it will help us systematize the use of clinical preventative services, which, if this was done for cardiovascular conditions, better treatment of hypertension, recognition of blood pressure screening, recognition of cholesterol and risk factors, it could potentially save 25,000 to 40,000 deaths per year among those underage Medicare and up to 100,000 deaths a year among Medicare age patients. So several meta-analyses have looked at that. A conservative one that essentially for every dollar we invest in staff and systems to do Medicare prevention, they estimate that the country gets back $3. Just reducing, this startled me, if you just reduce diabetes and hypertension prevalence by 5%, so a small decrease, that's a relative decrease of 5%, not absolute, you can save $9 billion over 5 years, and the resulting comorbidities would add up to a tremendous pot of money. So systematic prevention and wellness for the Medicare age has tremendous potential for the triple aim in saving us a whole lot of healthcare dollars to spend better ways. There's another way to look at benefits. First of all, for the patient has improved health and wellness. The patient, due to the health and wellness, should theoretically have cost savings, meaning they're going to have potentially fewer emergency department visits. If their diabetes is under better control, they may have decreased office visits through cancer screening, optimal vaccination. Maybe they won't get flu, they won't get pneumococcal pneumonia, etc. And lastly, and probably best proven, is both physicians and patients agree having a yearly preventative visit clearly improves the relationship, and it gives you a dedicated time to focus on prevention and wellness. And to be fair, though my practice culture, my docs are very interested in their quality metrics, in improving their pneumococcal rates, their hypertension screening rates, tobacco screening rates, etc., the single biggest, immediate win is everybody in the team, including the patient, loves having 30 minutes to talk to the doctor and the nurse, not focusing on something that's going wrong today. And so that's a really powerful time. From a practice-centric perspective, you improve quality metrics systematically. You increase practice revenue because this is a yearly renewable resource that's new work, it's new dollars. And it is not common that Medicare puts in new dollars to the pie. By finding things that need to be done, it does drive downstream ancillaries and referrals. And practice population, meaning your patients overall then become more attuned to prevention, wellness, and potentially become more engaged in their health care. And that has tremendous benefits for the practice. And lastly, for the ACO, building a system that a substantial portion of your Medicare age patients will come in for their free preventative time will dramatically help your attribution, meaning every patient will get in every year. You won't have patients dropping off because they weren't seen. It also gives you an opportunity to address risk score items to increase your CRG or HCC scores. And we'll talk about that in the workflow section. So what's this valued? Okay, let's talk about dollars and cents. So the initial Medicare annual wellness visit, GO438, is 2.4 RVUs and $166. I think that is last year's allowable. I have not updated it since January 1st. I don't think the 2017 allowables are even published yet, but that's what it was. The subsequent is 1.5 RVUs, $110. Now you see breast and screening has additional physician work. It has additional payment. I don't have the Q0101 code for the prep and transport of the Pap sample. You should be separately billing that. Those are separately billable. We'll touch on that next. Basically, any Medicare covered preventative service can be added in the separately billable to the Medicare wellness visit. That includes depression and alcohol screening. Those have separate codes, separate dollar values. Medicare will pay them all at one time. That's unusual. Usually when you do an E&M visit, everything else you try to bill in terms of prevention or procedure is disallowed. And lastly, I listed, compare this, your usual 55-year-old adult insurance annual visit is typically a 99396 established patient age 40 to 64. That's worth $126 and 1.9 work units. So you see that the subsequent, which the 99396 is typically a full 30-minute visit, almost all physician time, besides whatever pre-visit planning and advanced rooming your teams do. That's 30 minutes of physician work. The subsequent wellness visit has a bit fewer RVUs, but a much higher slice of practice expense because they're expecting it's more staff engagement and time, and it pays about as well. It is less than 30 minutes of physician work. We'll get to that. Additional E&M services. So any significant separately identifiable work that you do at this visit can be coded and billed with a 25 modifier. You can include it on a single note. You don't have to split out two different notes. And the language is significant separately identifiable work. And how you interpret that is anything you do not required for this service and was not valued to be paid for this service could be billed in addition. And I'm here to tell you Medicare is absolutely covering GO 439 for subsequent wellness. If Mr. Brown, you have time, it's convenient for Mr. Brown, and you choose to also address his hypertension, adjust his lisinopril, ensure he's on baby aspirin, make sure his CAD post-stent is silent, and order some lab for yearly hypertension. If that's a visit you would have done by itself and billed a 99214, probably, right? 3 chronic problems that you updated, you'll do exam, and you'll order lab and prescribe medicine, that's a 99214 visit. If you do that and document it, you may bill that in addition to that. So suddenly, you have a 1.5 RVU for the GO 439, you have a 1.5 RVU for the 99214, so suddenly you've got a 3 work unit visit or a combined reimbursement of $219 and change. Instead of the back in the old model where you brought patients in for the comprehensive exam, tried to touch on everything and cram in prevention, you were getting essentially a $115 for that. That's typically a time there's lots of questions. I'll pause for just a second, see if someone wants to clarify or ask a question about that. Okay,
this is Logan.
we'll start, John, and come back to it.
Sorry, this is Logan. We were doing a single note for the hypertension. And
I'm sorry, you cut out. Say it again.
Said we were doing a single note for the annual wellness visit plus hypertension or lipids or whatever else. And then we were in either, I can't remember how it came about, but we were encouraged to split that out into 2 notes. You routinely do them in 1 note and do not have any issues with that?
We do routinely do them in 1 note. Medicare has explicitly said doing it all in 1 note is fine. Most of your coders, that makes them very uncomfortable because in general nobody paid an E&M and a preventative service at the same time. If you had a payer who would do that, it was hard to make clear in 1 note what bullet points of history, exam, decision making were going to the preventative service, right? And what bullet points, if you're using 97 guidelines, what bullet points are going to the E&M service, right? It's different. In the Medicare Wellness Visit, there is no required history. It's required that you review it. There is no required exam. There is no diagnosis. There is no medical decision making. You're not diagnosing anything, prescribing anything, or managing anything. If it's an established patient, you only need 2 out of 3 elements to set your billing level. So you discount your blood pressure, your height, weight, BMI. Every other bullet point of exam clearly must go to the E&M visit, and anything you diagnose, treat, update, or order that's problem-focused obviously goes to the E&M code because none of that is required or covered in the Medicare Wellness Visit.
Okay.
So you may get local advice that's different. I think some of that's just traditional, but Medicare has been okay with it so far. I cannot point to specific audits or cases where this has been legislated or audited and published about. So I think as we do more of them, we'll get more experience. Right now, only about 4% of the Medicare population has ever had a Medicare Wellness Visit. So it's still rapidly building.
Okay, thanks.
So revenue potential. This is for a single provider practice, 2,000 patients. If you're 35% Medicare, which is kind of an average, it means you have 700 Medicare patients. If over a series of a year or 2, you can build a system where, call it 70% of those patients will come in for a yearly wellness visit. That's 490 services a year. Assume they're all subsequent, and that's 54 grand a year. If you're a 3, 4, 5 provider practice, that quickly adds up, quickly. And no matter how your salary and compensation is done, whether it's RVUs, it's net after expenses, or it's some other model, this is to everybody's benefit. Now, a way to do this is to essentially add an LPN or an RN, or use an LPN or RN to do these services. Again, Medicare has explicitly said that's okay. And this is just saying ignore value-based. So in the value-based economy, you'll have care management fees, you'll have shared savings, you'll pay for people out of that pot because this work improves your quality and reduces your utilization costs. All of that is true. If you're still living, however, in a pure fee-for-service world, here's a pro forma showing essentially you can hire an LPN and 3 subsequent Medicare wellness visits a day pays for the salary of your LPN. Now, obviously, I've used rough numbers. Your local salary benefit numbers may change, but basically, in a fee-for-service, what we call Curve 1 economy, if that's your environment, you can absolutely add some staff to help do this. 3 a day covers it, and then you've only spent 0.37 of that nurse's time, and there's lots of other great stuff they could help you do. Okay, so in 2010, the ACA removed all cost sharing, meaning copay and deductible, for all Medicare-covered preventative services with the exception of the 4 at the bottom that still don't have any deductible but do have copay. I really can't parse out why that decision was made per se, but that's what it is. The 4 that I have highlighted, alcohol, depression, pelvic breast exam, every year for high risk, every 2 years for average risk, and the smoking cessation counseling, those can all be done at the Medicare wellness visit and billed in addition to the GO439, GO438, etc. That is very above board, no sleight of hand. Medicare absolutely wants us doing these services and is happy to pay for it. Realize also that all of those, depression, alcohol, smoking cessation, those are also billable on top of an E&M service. So if you are systematically doing alcohol abuse and depression screening once a year for your ACO measure, tobacco cessation counseling for your ACO measure, using the standardized instrument in the EMR, even though the patient came in for a sore toe and a blood pressure check, you can bill the G code to Medicare with a 25 modifier, and they are paying it every time. So that's probably some additional revenue and or work units that are not being systematically captured. From the ACO's perspective, we want everybody seeing their personal benefit to that because everybody wins. The patient wins, the practice income revenue side wins, the provider salary perspective wins, practice expense wins to help you build a better system, and the ACO wins. So preventative codes, I've just kind of went over this. There is a detail that depression screening is not paid with the initial wellness exam, initial wellness visit, only the subsequent. Not entirely clear why they made that distinction. The rest of them are covered initial or subsequent. A few of them, or a bunch of them, aren't covered during the welcome to Medicare visit, but again, that's not the topic of today's talk. This is a really good place. It's a new interactive site if you want to know details of, and this is also available when you go to this website as a downloadable PDF. It has all the details. It tells you who's eligible, whether it's copay or deductible, and if it's separately covered with a 25 modifier, and that's where I got the data on the prior slide from. This is a really useful resource to investigate if you want to know details about any one of these. So lastly, as I said, 31.5 million Medicare patients, only 4% last year received an annual wellness visit. That has implications. It's a huge growth area. I can see for a large, if you're a 5, 7, 8 provider office, you have more Medicare wellness visits to do in a year than any single provider is going to be able to handle. And so as I said, it's going to be kind of all of the above. Providers do it and nurses do it cooperatively, most likely is what will win for us going forward. And do realize that Medicare is actively promoting Medicare Advantage plans. Medicare, there's public announcements, there's PR campaigns, they're sending brochures to patients encouraging them to get their annual wellness visit. So if we don't respond and build the capacity to do this, do realize there are plenty of people who see this pot of money that are happy to help us with this. This is my favorite. This is our friends at Lifeline, the people who bring you the head-to-toe sonogram and CT trucks that drive around to community centers and churches and do head-to-toe cash CT scans. We love them dearly. They actively advertise for providing the wellness visit. Nothing in regulation prevents them from billing Medicare for it. If it's done, you won't be allowed to bill, or they won't be paid for you. Obviously, ACP, AOA, and AAFP have protested and objected strongly. Right now, there is a website to check eligibility and to know that it's been paid in the last 12 months or not. Lifeline has said, well, we just checked the public website and prove it's available to us, and any practice could do the same. But frankly, it's up to us to not be out-competed for our own patients. Now, workflow. So a completed Medicare wellness visit looks like there's an updated complete history, care team, and end-of-life desires when appropriate. There's a documented health risk assessment and all the required screenings. There's a blood pressure and a BMI. And you've reviewed and updated all the Medicare covered and medically recommended preventative services. Now, do realize that Medicare covered and medically recommended preventative services, those two circles don't overlap 100%. And so we certainly want to touch on all the ones that we feel are sound and good medical conscience and recommend whether Medicare covers or not, but it's important, and Medicare specifies you have to touch on at least all the ones that Medicare covers that are appropriate for the patient. So the visit note for this service is extremely brief. If you're not doing other services, chief complaint, here for Medicare wellness visit. HPI, here for Medicare wellness visit, hasn't had in the last 12 months. No review of service is necessary. Your exam is vital signs and BMI. Those are probably done on the intake of your EMR by your staff and pushed to your exam field probably. So you don't even need to do exam necessarily. The diagnosis will always be that it looks like ZOO, but it's the Z00 adult well visit code. Then there's a list in some fashion of the risk factors and conditions and recommended interventions. So several ways to do that. And then there's a preventative plan. It's either done in the EMR that you can print and give to the patient. It can be typed out on a fillable PDF, and I have a version of that you can then print and give to the patient, scan a copy, or it's a paper form that you copy and scan. So at least three ways to do that. You all probably will think of additional ways. I understand that Medicare Epic I have heard, has a decent preventative plan within it. Cerner does not so far unless you have their care management platform. So that's what a completed note looks like. So ideally, your EMR would guide you through this turn by turn. It would help you. It would, auto-complete. In a perfect world, it would auto-complete when the last preventative service was and let you only address when it's due for this patient. It would ideally allow you to easily document all the requirements, but I'm not aware of any EMR that does this perfect. I've heard of a few that maybe do it well. I'm sure your all's experience is widely varied, as is ours. As we experiment with this, as you build the service, and as the EHR companies improve their game, because Medicare is pushing them hard on this, I don't think there's anything wrong with using paper forms to experiment. Obviously, it needs to be coordinated with the ACO to be sure you're gathering the information that the ACO needs. And I remember seeing that Blue Cross, for your ACO contract, has a kind of a standardized intake form that is supposed to be done once a year, and that's what adds up to their risk points. So I mentioned 3 possible workflows, and I want to touch on that briefly. So first of all, there's the usual workflow. Patient shows up, patient is roomed. You go in, the provider goes in and does the entire service, meaning you ask all the screening questions, you by hand update all the history, you by hand start building the note and the preventative plan. That can be done in a 30-minute visit, and that is basically just like we've always done annual visits, right? So that should be very comfortable and very familiar. A benefit to that is it's really easy to add in other E&M work because you've got 30 minutes. And if the patient says, oh, by the way, look at this mole, it's a funny looking mole, you document complaint, exam, and diagnosis for funny looking mole, and then choose to refer and set them up for a punch biopsy, then that is a very appropriate 99213 that you then, or 212, depending on which document, that you can bill with the 25 and get the additional value. So that's one workflow. Second workflow is the team workflow, and this is the team, regardless of how you build your teams, working with the provider, enabling and speeding up their work. So this is following the chain of everybody trying to work at the height of their license. So essentially, this is optimized by the required screenings and the health risk assessment sent to the patient in advance, mailed, they download it from the portal, the front office sends it to them when they schedule the visit, or it can be even handed out at check-in. So when the patient is roomed, they have those screenings and HRA already filled out. The medical assistant or whoever does your rooming simply transfers that into your EHR form, assuming you have one built. If you don't have it built or it's not available, then it's even faster. The provider then comes in, has to review and validate all of those, address risks and concerns, then complete the preventative plan, and finish the brief note. That takes about 15 minutes of staff time, more or less, depending on your workflow, and about 10 to 15 minutes of provider time. I've done this lots of times when I'm not doing E&M services on top of it in 10 minutes. That workflow also makes it possible to add E&M work in here, but if it was a 30-minute time slot, the staff took 20 minutes, I have 10 minutes left before I'm running late, it makes it harder to touch on the 3 or 4 chronic problems and order the lab and adjust the diabetes medicine, et cetera, right? Then the third workflow, and that is with your licensed nurses doing the service independently, billed under the provider's number. That is completely legit. Medicare is paying it. Sometimes both nurses and physicians have some heartburn about this, but I just want to, think it through. The nursing staff that do this are not making any diagnosis. They're not managing any medical problem. They're simply attaining history, reviewing screening measures, and starting a preventative plan. That is all very classic nursing services. Inpatient nurses and inpatient discharge coordinators do that type of work every single day. It just has not traditionally been done in our practices. If the screenings and the preventative plan are completed, you would want to have basically a good teaching program and then a standing order or standing guidance for your practice about when each preventative measure is due for which patients, so they're acting on your care protocol. Then those documents are all sent through the EMR to the provider to co-sign, and then it's billed. The benefit to that is it doesn't take any provider time. You can easily pay for it out of new revenue. It expands the reach of the team in the office, and to be frank, this workflow has probably been better received by patients than the combined workflow. And partly that's because every old Mrs. Smith loves to have 30, 40 minutes to talk to a nurse about health and get some hands-on education. It really increases engagement. The minute the provider is involved, it's hard for it not to be a usual problem-focused visit, and you get lots of the, but my thumb hurts and look at my sore toe and what do you think about this mole? And your time gets eaten up pretty quick. Other needs are identified. Nurses are smart. They're well-trained. I'm thrilled to move to value-based care. We're able to unleash their power in our practices. This lets them identify, the blood pressure is not well controlled, diabetes is not well controlled. I need to refer them for colon cancer screening and get those services acted on, and even referred back to a medical visit if needed. So you empower this by the patients coming prepared with all this information. That's fairly standard workflow. And we've touched on this. It can all be done in 30 minutes of time. How much is provided and how much is staff depends on how you build it. So Dale had this question, which is an excellent one. What do you do with a patient with deficits who can't do some of the, quote, required screenings? Medicare has not specifically addressed this question. There are two responses. One is in some of the preventative services that Medicare covers, there is a specific phrase which is the same phrase highlighted. A patient is eligible if they're competent and alert at the time of the counseling. That phrase is not seen in the Medicare specificity for the Medicare wellness visit, which implies that is not necessarily required. And again, realize that all the history, most of the screening could be completed by a loved one who lives with the patient just as well as the patient. The other possible partial answer is an analogy to E&M visits. In the coding and documentation guidelines, with additional commentary, it is accepted that if a patient has a deficit that keeps them from preventing one of the elements, if you document that, it is assumed you have done the element. Like a patient with dementia sent from a long-term care facility, I typically have a phrase that, history is obtained from facility staff and records. Patient has dementia and is unable to provide history of present illness, review of systems, or respond to exam and questions. And so that essentially gives you credit for those elements if it's documented. So I think all that together says this service is still doable and billable for a patient with certain deficits. So there's some staff training, which I will be happy to provide copies of. I see we've got about 5 to 6 minutes left. This is scripting. So this service starts with a phone call. And I want to caution you to not use the language Medicare Wellness Exam. If you use the word, it sets up a failed expectation because the patient will go away saying, I called for a Medicare Wellness Exam. The lady on the phone scheduled a Medicare Wellness Exam. When the nurse roomed me, the medical assistant said, oh, I see you're here for a Medicare Wellness Exam. And then when the doctor saw me, he didn't do any exam, right? Medicare's language is specific. It's called, in every format possible, it's called a Medicare Wellness Visit. So I'd encourage you to train that language. That expectation starts when someone calls in and asks. So when a Medicare age person calls and they say, I need my annual visit or my annual exam, you actually don't know what they mean. You don't know if they mean the comprehensive deal with every problem and prescribe every medicine, or if they mean they want their free preventative and wellness service. And so this is a scripting that we've developed to help clarify that. It also, over time, allows you to build this wellness perspective in your Medicare culture. Then there's a visit tear-off. For about the first 2 years we did these, this was a gummed pad in the exam room, and for a long time, for more than a year, basically until the Medicare patient started saying, oh, I've gotten that 3 times, I don't need it, every Medicare patient would have one of these gummed tear-offs torn off and given to them at the time of rooming or the time of checkout. So this is retraining your Medicare age population about their free benefit and about what's included. And differentiating, it's not dealing with a problem or a new diagnosis, it's all about wellness and prevention. And then lastly, we do have an outreach letter that can be used to be systematically sent to patients to alert them of the same information if you want to start a campaign. So this could be either from the ACO or practice by practice. So this drives appropriate volume, they present, you're able to improve your quality metrics, etc. Here is the Medicare Wellness Visit Tool for Preventative Plan, which I have mentioned. And then last I want to show you, so this is an example from our Cerner Millennium environment, how we have built this. It's not perfect by any stretch of imagination, but it works. And so essentially there's a preventative Medicare prevention tab that you open it up, and if you can see my cursor, it drives you down through the health risk assessment, the history, the screening, cognitive depression, hearing, vision, fall risk, home safety as part of the HRA, and then prevention. It drives you as you fill out the screens from one tab to the next. The process drives the requirements. Here's an example of what the health risk assessment looks like, and this is just one of 2 screens. As you answer positives, additional details open up. Like in the brief home safety screenings, have you fallen? Are you afraid of falling? If you say yes, it opens up to a more in-depth home safety assessment. And then lastly, here's the depression screening. The cognitive screening that shows mini-cog. If it's positive, you're allowed to flow directly into the full MMSE and complete that more in-depth if you desire. So each of you have an EHR platform. Hopefully your vendor has provided some of this content. If not, it's an example of how it could be built. This was not stock Millennium content in Cerner. This was stuff that we engaged with Cerner and had built over a laborious, painful 18 months. This is a quick text I use in the plan section. So if your diagnosis number 1 is Medicare, annual wellness visit, the Z00, diagnosis 2 through whatever number can be every other chronic diagnosis you intend to touch on. If you address its stability, chronicity, or status, it's a valid diagnosis to document in that visit. You can separately bill for it or not if you do any work with it, but just listing it and having had a brief discussion for its status and update makes it valid to get that diagnosis on the bill that goes to Medicare or to update your risk score. So here's the plan. I just say this is a quick text, and with about 3 keystrokes, I can insert the plan number 1 for Medicare Wellness Visit is we did the Medicare Wellness Visit. So here's additional resources, including some of the articles I listed separately. And we're through the content about 5 minutes later than I hoped. I will pause for questions, and if not, I'll be happy to take those offline. I appreciate your time today. Dale, I'll pass it back to you.
Okay, thank you, Lee. Any questions? Anything that we can answer specifically? If not, you can email them to me or email them to Lee, and we will try and answer them. And if there's enough of a number of questions, we'll put them on to Basecamp. I'm not hearing anything, so I think with that we're going to say thank you again to Lee, and thank you to all of you who have attended. We appreciate that, and we will end our webinar. Thank you very much.
All right. Thank you, everyone. Have a great rest of the week.